Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation.
So welcome everyone, I'm Nora Hanna. I am the Chief Engagement Officer at Sun Health, which is a really interesting role. I oversee our foundation, which we're going to be talking a little bit about today, as well as our marketing and our branding and all of our partnerships throughout the community, because we have some of our key partners here today, Hospice of the Valley and others, that we work with to ensure that our community has all the health resources that they need to have access to. And you know, this goes back to kind of the history of Sun Health. We were born out of, really out of volunteerism more than anything else. In the 60s when Sun City started, it was opened on January 1st of 1960. And at the time, you could not get a ambulance to take you to a hospital. The two closest hospitals were Youngtown and Central Phoenix, but it was too far for an ambulance. So a group of community citizens were like, we need to fix this. And sat around a kitchen table and probably a boardroom table at certain points, right? And decided we're going to raise money and we're going to build our own hospital, which I think is just a real testament to commitment to community, commitment to the future, paying it forward. And they did just that. And they raised the money and ended up building Boswell Hospital that we all know in Sun City. We're going to talk a little bit more about Boswell today and where it's headed. But that was the genesis of Sun Health. And subsequently, they were so successful at running the Boswell Hospital that they opened the Del Webb Hospital. So Boswell opened in 1970 and Del Webb opened in the 80s. But another important element of the history of Sun Health is 40 years ago this year, Sun Health founded the Alzheimer's Research Institute that is on the campus of Boswell. And the reason I think that's so important is because it was, in my opinion, and maybe only in retrospect, a real pivot point for Sun Health, because it's when we started to think about preventive health, not just how are we going to treat acute care. If you need an emergency, you need a hospital, right? But how are you going to take control of your future and think about how we can remain healthy now and what we individually need to do. So all this research around Alzheimer's as a preventive measure, I think, has been really instrumental. In 2008, the hospitals and the Research Institute merged into Banner, which continues to be our partner today. So the Sun Health Foundation raises money for all three of those institutions as we move forward to ensure that the future of our community still has that level of health care. That's me. There we go. And now I've told you our story. What I really love is our vision. Sun Health envisions a world where people live longer, healthier, and more purposeful lives. So we really like to think that over our 60-year history, how we have accomplished this has changed, but our mission hasn't. We've always been about this singular mission. So now you probably know we have 4 very large life plan communities. I think some of you, how many are residents of La Loma? I saw, yay, yay. We have, again, amazing residents. We have Sun Health at home. which is for people who want to age in place, and it gives them the wraparound services for this. We have our Center for Health and Wellbeing that offers myriad services on preventive health. We have a memory care navigator that works with individuals and families dealing with any form of dementia, how to get access to those resources, and a lot of work around dietary things. We have a nutritionist on staff, so we're always working with people. Obviously, diabetes is something that's affecting a large portion of our population. And nutrition affects your brain health and all sorts of other things. So we're really trying to provide comprehensive services not only for our residents, but for the community at large. What we offer in the Center for Health and Wellbeing is free for everyone. And generally, it is not our residents who are taking advantage of that, it is the community at large. And now we're going to talk about today and what we have going on for us today. And I'm particularly interested in hearing from Dr. Clayton, not only because of her reputation, which I've heard about her from 2 or 3 different people from within the Banner network, but also because we're initiating a very significant investment in the radiation and oncology facility on the on the Boswell campus. And that is the area in which Dr. Clayton operates. So you are a transplant from Canada. I definitely want to hear this story here. Board certified radiation oncologist who specializes in thoracic and cutaneous oncology. So I know it's subcutaneous, so you're gonna have to fill me in on some of this. I love coming to these because I learn so much. I feel like I'm attending medical school. After earning her medical degree at the University of British Columbia, Vancouver, she completed her residency training at University of Calgary in radiation oncology. I think you should go back there for the summer. I'm just saying, it's coming. And
I've already booked my
there you go, there you go. She's board certified by the American Board of Radiology and the Royal College of Physicians and Surgeons of Canada. And she's co-director for the Thoracic Multidisciplinary Program. I get points for saying all those correctly. She sees patients through the Banner MD Anderson program. So please join me in welcoming Dr. Clayton.
Thank you, Nora. Thank you, everybody, for having me here today. Really excited to get a chance to speak to all of you. Appreciate Sun Health for putting this together. I must say I haven't had a chance to attend one of these sessions before, but it certainly sounds exciting, and I'll try to do my best to maybe come in the future as an audience member as well. Yeah. So this is my clicker. Let's see. So today I was going to talk a little bit about the role of radiation therapy in curing versus controlling cancer. And before I even start talking about any of this, for the most part, a lot of us really don't know what radiation therapy is. I know when I was a kid, I remember a family member undergoing radiation, and I thought they were just swallowing a pill that would go down into their stomach and cure the cancer. It wasn't until, and I'm embarrassed to say this, but I think I was in college before I learned how radiation is actually delivered. Having said that, I think it's not uncommon in the general community, but even in the medical community, not to know too much about radiation. So the first focus of my talk is really going to be talking about what radiation is, how we deliver it, how we plan it, and then I'll focus on some of the diseases that we treat with radiation, either to cure or sometimes to control the cancer. And then there's another exciting area about radiation oncology that's coming to light, which is treating non-cancerous diseases with radiation. So I'll talk a little bit about some benign treatments that we do with radiation as well. Feel free to interrupt me at any time. This can be as interactive as you want. With regards to my introduction, so yes, I came from Canada when I was, I think in 2014, I moved to Alabama and took a job at UAB. Actually, Dr. Broussard, he was there as well, although we never overlapped. But I was there for 4 years as a thoracic radiation oncologist, and then I moved to Boswell in 2018. And I've been there for the last, I guess, 8 years now. I primarily treat lung cancers, but I also treat cutaneous cancers or skin cancers, and have a little bit of a focus on breast as well. I have expanded my practice out to the Gilbert area as well, so I'm a little bit all over the valley, but my focus has always been Boswell. All right. So just a little brief introduction about what radiation is. Really think of radiation as just high energy x-rays. So really no different than getting a chest x-ray, except the energy is so high that it can damage DNA of cells. That includes cancer cells, but also our normal cells in the body. The difference, however, is cancer cells can't repair themselves. The normal cells of our body have the ability to repair. So over time, cancer cells just die off, whereas our body finds a way to repair itself. That's the underlying principle of radiation, is just damaging DNA of cells. And we know that it's a non-invasive procedure, which is what I learned over time. No cuts, no surgery, no IVs, nothing to swallow. It's really just an x-ray. It's highly targeted, so we narrow in on where we want to treat based off of diagnostic scans like CT scans, MRIs that you may have had, a PET scan. And it's used in about half of all cancer treatments. So it's a fairly common thing to experience if you are going to be dealing with cancer. The radiation process can look a little bit cumbersome to some from the outside. This just represents the timeline of radiation, from the time somebody meets with a physician at consultation to the time they get treated. There's multiple steps along the way that happen. Some of those take place behind the scenes, so everything in green happens without the patient's knowledge, whereas they'll come in for a consultation, we'll have you come back to do a CT scan or a mapping CT scan to plan out the radiation. And then in the background, we'll get to work planning the radiation, and that can take sometimes a few hours if it's a very simple, straightforward procedure, or sometimes it can take a few weeks if it's a very complex procedure. So time from consultation to treatment can be a few hours to a few weeks, just based on the complexity of the plan. So the first step is something we call radiation simulation. It's a custom planning appointment that puts the patient in the treatment position. We basically want things to be reproducible every day of the treatment. So we create these custom vac blocks or molds. These are little molds that we inject air out of, so that they become very, very solid. Every day of the treatment, these are reusable, so we're not just creating custom ones for each treatment. We put some skin marks on the patient. There was a time we were using tattoos, but now we've gone away from that, and actually we use a Sharpie with some tape on top. It's nothing interesting, except sometimes when patients do have a tape allergy, we'll go back to tattooing, although most of us have lost our tattooing abilities. And then we take a CT scan. Once that scan is done, this is probably what I do most of the time when I'm not seeing patients. It's called contouring. So that CT scan goes into a computer and it gets loaded up there. And then what we do is we start targeting what we want to treat. And in this case, what we're trying to target, I don't know if there's a laser here. It's hard to see, but there's a small lesion in the lung. It's circled in red. That's what we're trying to target. And then we also want to draw out what we don't want to treat. So in the middle sits the heart. Just behind that in green is the esophagus, the spinal cord, the chest wall, the lungs, all of that. And once that's done, I send this over to one of our team members called a dosimetrist. They come up with a radiation plan. And so you can see the lesion is kind of in the middle right there of the chest. And we're coming at it from many different angles. So we can manipulate the fields, the energy of each field, the angle of each field, the position of the table where the patient sits as well. And then also, sometimes we put in custom devices like a bolus material or something else to modulate the radiation beam. All of this works towards making that plan very conformal. when we treat a cancer in the lung, that's a few centimeters in size, let's say an inch in size, we only give about 1/4 of an inch margin for error. And this is a moving target, so we're able to do that by manipulating all of these. These are the different types of radiation plans that we sometimes see, and you may hear people talk about proton beams, brachytherapy. Just want to give you an overview of what that actually means. So on the top left, that's what we call our more basic 3D conformal radiation therapy. These are 4 static fields trying to treat a prostate in the middle. The red is the high dose area, the green is the medium dose area, and the blue is the low dose. So you can see the 3D conformal, we probably have the most amount of low dose radiation spread to the rest of the body. As we move further along, the treatments get more and more complex. So IMRT, what it's doing is essentially modulating the radiation beam. So we have little lead leaves that move in and out of the treatment field. And as they're doing that, it conforms the radiation dose. VMAT is a special type of IMRT. And what that does is, as the lead leaves are moving in and out, the arm of the radiation moves as well. So it becomes even more conformal. Proton beam therapy is a special type of treatment whereby instead of, all that plan is at the bottom is one field coming from the right, one field coming from the left, meeting in the middle. But what you can see is very low dose in the peripheries. This is great for especially treating kids because you want to avoid low dose radiation to normal organs in the kids because of the risk of secondary cancers. But it's also great for treating something that's very close to a critical structure. So sometimes we do not have a proton beam facility within Banner MD Anderson. That was a question that was asked. Mayo Clinic has one, and we will refer all our kids to Mayo Clinic for their radiation treatments. The last one is brachytherapy. So some may have had experiences with this either through family members, but brachytherapy actually involves inserting seeds into the prostate to deliver the radiation. So now you can see that plan is about as conformal as it gets. It's great for treating a structure like the prostate where we want to avoid radiating anything else in the vicinity, but we want to get a very high dose to just that spot. So just a little bit about the types of radiation therapy that you may hear about. After all of this is done, there's another step for our complex plans, and that's called a physics quality check. Our physicists work with us to essentially do a mock run for the patients. So once we have a radiation plan, it's not just sufficient to bring the patient back to the clinic and start their radiation. We want to make sure that that's the right plan. There was a case a long time ago, and this is now decades ago in New York, where an IMRT plan was created for a patient, and the leaves that I talked about, those lead leaves that move in and out of the radiation field, weren't moving. And unfortunately, the patient passed away because of the high dose of radiation that was delivered. It was that incident that prompted us to develop this process to ensure, prior to coming in for radiation, we do a mock run on a phantom patient to ensure what we think we're delivering, we're actually delivering. But this is one of the highlights of our radiation program, is that we never bypass this step. And that's true for all radiation facilities. But it can be frustrating because sometimes that will delay the start time for patients. And finally, this is the machine we use to deliver radiation treatments. This is called a linear accelerator. Patients lie on that very comfortable table right there in the middle. And the arm of the radiation, the C arm, moves around. And it can move 360 degrees around that table. And the table can move as well. So one of the things we also have to check for during that physics quality assurance is to make sure that nobody gets hit. And that can sometimes happen as well. So collisions can take place just because everything is moving. But most treatments are actually delivered just within a few minutes. You don't have to take any extra precautions after your treatments. It's just like getting an x-ray. You go home, you come back, you go home. A few weeks later, you're done. once the patient is set up on the treatment machine, it's not sufficient just to turn the beam on generally. We also want to make sure we're in the correct position. So going back to that CT simulation scan that we did to begin with, we then take a CT on the treatment table and we align it with that original CT to make sure where we think we actually are, and then we beam on. So that's an extra step for a lot of patients, especially when we're treating very, very small targets like these. All right, a little bit of focus of this talk is going to be about cure versus control of cancer with radiation. So what does curative radiation mean? In simple terms, it really just means to completely eliminate all cancer cells that we're trying to target. And it can be used alone. So for example, with some of those lung cancer cases I was showing, early vocal cord cancers, prostate cancers treated with brachytherapy. Sometimes it's used with surgery, or before or after. So for a lot of head and neck cancers, we'll do that. Breast cancer is a very common example of that. And sometimes we use it with chemotherapy or something called immunotherapy. And so with lung cancers, more advanced lung cancers, it's not sufficient to just treat with radiation or surgery. We often have to introduce chemotherapy as well. So yeah, these are just some examples of curative treatments. Skin cancers are very commonplace, unfortunately, in Arizona. I do have a skin cancer practice as well. And some of those treatments I'll show you in a little bit can be very straightforward or sometimes very complex to treat as well. But radiation on its own is sufficient to get rid of most skin cancers. Early stage breast cancers, after patients have had lumpectomies, will often do radiation. Prostate cancers, head and neck cancers, and early stage lung cancers. In most of these cases, the radiation is given at a very, very high dose. And depending on location, we'll either split it up over several weeks, or we'll do it in a very short course. And a lot of the times why we do it over weeks versus a few days boils down to where the tumor sits. So it's a little counterintuitive, but the more treatments we're giving, generally the more gentle we're being. The fewer treatments we're giving, the more aggressive we're being when we're talking about controlling the cancer. So that little spot that I showed you in the lung, that was treated just over 4 days. A very high dose of radiation, but just 4 days. Same dose of radiation that we would normally deliver if we were treating in the middle of the chest over 6 weeks. So a little bit about why we sometimes choose those fractionations or different schedules. This was a patient, it's going to be hard to see this, but maybe just to orientate you in terms of what we're looking at here, imagine the head is behind the screen, the feet are coming out of the screen, and we're looking up from the feet, taking slices like this as we're looking up. So the left is the right lung, the right is the left lung. This scan is a CT scan. It's kind of whited out just to make the lungs pop. All those little squiggly lines, those are blood vessels in the lung. What might be hard to see is right at the top in the left upper lobe is a small area we call, it's a GGO, a ground glass opacity. And that was biopsied and shown to be cancer. We treated it with 4 30-minute treatments of radiation. This was back in 2019. In 2026, now you can see it a whole lot better. And you'd think on that CT, oh gosh, it's gotten a lot bigger. We've made it worse. But in fact, that's the scar from radiation. And the way we can sometimes tell what's a scar is to get a PET scan. So a PET scan is a CT scan, but superimposed on top of it, they inject a radioactive dye that's labeled with sugar, essentially. That radioactive substance goes to any part of the body that's very active. So cancer is active, infections are active, the brain is active, so brain lights up on a PET scan. You can see on that PET scan that there's no activity in that tumor. So this is a scar from radiation. So this is somebody that was cured of their lung cancer from radiation. And generally we say if we've made it past 5 years with lung cancer, you're cured. So that was our goal with this patient. This is a skin cancer treatment. So superficial skin cancers that are less than 3 millimeters deep and generally less than 3 centimeters wide can be treated with a device called skin surface brachytherapy. Essentially, we're delivering radiation very superficially just through this metal applicator. It's applied directly to the skin. There's no pain when we apply it. Usually there's 8 to 10 treatments. We deliver them over twice a week, sometimes 3 times a week. And the goal is to get rid of the cancer. And it works about 95% of the time. So very effective for very small tumors. We use it a lot in locations that are otherwise difficult to treat with surgery. So ears, noses, but even hands and feet, just because those are areas that don't always heal as well from surgery. But this is a very effective and easy treatment to deliver. Sometimes, however, the skin cancers are not very small, and the treatments have to be a little bit more complex as well. So this is a case where the cancer, it's hard to visualize it here, but on the right side is the CT scan, and that's at the level of the nose. And the cancer basically covers that entire nose. For us, with radiation, we like straight edges. We don't like to treat things at an angle. And so in order to create a straight edge, we made a cube-shaped bolus material that goes over the nose. And now we're able to target the radiation very simply by bringing a beam in from the sides. It was a complex setup, but a very simple plan. In this case, however, we had to treat this over 5 to 6 weeks just because of the location. It's very close to the eyes, it's close to your nose, the cartilage. We have to protect all of that. But we were able to treat this, and about a few weeks later, the patient was, I think, not very happy with me, to be honest, because radiation does cause a lot of skin reaction that happens not right away, but a few weeks into your treatments, and then it can get a lot worse a few weeks after. But about 4 weeks later, you couldn't see anything on the nose. It was gone, skin was back to normal. Over time, we'll probably develop some changes on the nose, little blood vessels may appear, but was able to keep the nose. Didn't require reconstructive surgery. Yes?
Are these only melanomas that we're talking about?
So this is actually a basal cell carcinoma. Yeah. Melanomas involve a little bit more involved treatments generally, and with melanomas, we usually prefer surgery. So the skin cancers I'm primarily focused on are squamous cells and basal cells. Yeah. But we do treat melanomas with radiation as well. And yeah, please feel free to interrupt. Yes, sir.
Skin cancer,
Yes.
you said you have your own practice.
Mm-hmm.
Does your business not come from referrals from other dermatologists?
Oh, absolutely. Yes, yeah. We do not biopsy in the radiation facility, so all of our referrals are from dermatologists. We have dermatologists within Banner, but also outside of Banner. But from the radiation standpoint, the brachytherapy, that skin applicator, that's all done in our practice. I will say that's actually not at our Boswell location. It's at our Thunderbird location, which is in Glendale. So a little bit of a distance to travel. Perhaps in the future we'll have that machine here at Boswell too. Yes? Yeah.
If you have basal cell cancer of the nose, what would be the difference between the radiation therapy or mole surgery?
Yeah, so Mohs surgery, and sometimes to be fair, we use both. So Mohs surgery on the nose is a stepwise process, and I can explain it a little bit, even though I'm not a dermatologist. Essentially what Mohs does is it creates an incision around the tumor, and at the time of the surgery, they're able to look at it under the microscope to assess margins. And if they're worried about the margin, they'll do a second procedure, a deeper cut. And again, if they're more worried about margins, they may do an additional cut. And sometimes if it's too deep, or if there's nerves involved at the time of the Mohs surgery, they'll refer to us for radiation as well. And so then we'll do radiation in addition to the Mohs surgery. However, in cases where the cancers are superficial enough, or we're worried that the Mohs procedure is going to be very disfiguring, we'll often just do radiation alone. All right, next I'll focus a little bit about radiation therapy for control. So where the goal is not necessarily to get rid of the cancer, but to control it, either to slow it down, shrink it, or relieve some sort of symptoms that the patient may be experiencing. This often applies when cancer has spread. So we're talking about stage 4 disease or metastatic cancer, or it's just not safe to remove the cancer. And that can be a case sometimes when we treat brain cancers, for example, where surgery is just not feasible. We talk about 2 types of control. So one is local control, where the goal is to shrink whatever the tumor that we see. So this could be a lung mass, shrink it to help with obstruction, stabilize a growing lesion. And the goal here is really to prevent complications in the future. There may be no symptoms currently, but we think if we leave it alone, there may be a complication down the line. So for example, a lot of spine cases where a tumor may be encroaching close to the spinal cord. It may not be causing any problems today, but it may in the future, so we will often do radiation up front to treat those. The other reason we do radiation for control is for symptom relief. So there's a few things that radiation can control relatively well when we talk about cancer-related pain. One of those is relieving pain itself. So often when cancer has spread to the bone, we can use radiation to help alleviate pain. And it's not immediate. It usually takes a couple of weeks for us to see the benefit from radiation, but it is non-invasive. The one thing that can be very quick for radiation to stop is bleeding. So not very large volume bleeding, but if there's a tumor that's causing patients to cough up blood, for example, we'll often do even a single treatment of radiation, and normally a couple of days later, we no longer see that blood. Sometimes it's to improve breathing or swallowing if a tumor is close to an airway or obstructing an airway and we need to shrink it. But again, with that, it will take some time for us to see the effects. And one of the other things I mentioned is just to reduce pressure on a tumor that may be encroaching the spinal cord. These treatments for control tend to be shorter, so they can be delivered just a single treatment, maybe 5 treatments, maybe 10 treatments, just depending on the clinical case. But unlike when we were talking about curing, we're using lower doses of radiation over a shorter period of time. But as I said, the relief can sometimes occur quickly within days, but sometimes it can take a little bit longer. One of the questions that does come up is why don't we always aim for a cure? And it may seem intuitive, but we have to recognize that sometimes it's the disease itself. If the cancer has spread so far that we cannot get rid of it. But sometimes it can be related to where the tumor is. It may sit in a location where it just makes it very difficult to deliver a high dose of radiation. So one of the examples of that is something called a chordoma. It's a tumor that tends to arise in the spinal cord or in the brainstem. And our brainstem and spinal cords cannot tolerate high doses of radiation. And the radiation for that tumor, the dose we would need to deliver is almost double the dose that the spinal cord can tolerate. So that's a case actually where we would refer patients to our proton facility at Mayo because they can usually deliver a much higher dose next to a critical structure like that. Sometimes it's the biology of the cancer. It could be a very early stage cancer, but you may have heard of small cell lung cancer. That's a cancer that, even though our aim is always to try to get rid of it, even if it's confined to the lung, we know that the risk of recurrence is much higher than most others. So often we will say that our goal is to control that disease for as long as possible, not necessarily to cure it. But I will say, with time, things are changing. Control has become something that's allowing people to live longer and really allowing people to live with cancer as a chronic condition as opposed to something that's necessarily life-threatening. That's not always the case. We recognize that it is a deadly disease. But our goal is to always help people feel better, maintain some independence, and especially if something is affecting the hip joint, the spine, get the mobility back, get back to what you were doing before this started. Today there is a little bit of a blurring between control and cancer. So some more advanced cancers, stage 4 lung cancers, for example, where we sometimes see a genetic mutation, a mutations that driving the cancer. We can target them with sometimes oral pills. And what we're finding in these patients is they're living a lot longer than what normally a stage 4 lung cancer patient would live with. And so in those cases, we'll often target sites that are metastases. So a patient has a single bone met or a single tumor in the brain. We will target that with very high doses of radiation to eradicate the tumor. And I have some patients with lung cancers and these types of mutations that are 7-8 years out from their diagnosis and living well without disease. So we are starting to see, based on the biology of the tumor, that there is hope, not just from the treatments we give from chemo or with the pills, but also using radiation to target those spots and eradicate the tumor itself. This is a case I wanted to show just to kind of highlight that point. This was a 68-year-old woman. She was admitted to hospital with a very large tumor that was obstructing the left upper lobe of the lung. And just to, again, give you an idea of what we're looking at here, this is a CT scan of the lung. This is at the level of the heart, and in the middle are some of the big blood vessels of the heart. At the back is the spinal cord. Let me see if point right here. This is actually the tumor itself. So it's not a very large tumor, but what this is a collapsed left upper lobe of the lung. And this patient was in hospital. We did some CT scans. This was the only spot we could see on her scans. So we talked with the medical oncology team and we decided, instead of just doing radiation alone, let's start with chemo. The goal was to control the cancer. She was obstructed, she was on very, very high flow oxygen. We needed to get that tumor to shrink. So I would say our initial goal was really just to control it. She was actually able to go home 3 days later. You can see on this scan, this is just 2 weeks after the tumor. The lobe has completely opened up. You can still see remnants of the actual tumor. It's a little bit hard to see here, but the lobe has completely opened. 6 months later, we did a PET scan. That's her pre-treatment PET scan, and that's her post-treatment PET scan, and there was no evidence of disease. So this was a case where we were able to help not just control the cancer by relieving those symptoms, but actually get rid of it over time with a longer course of radiation. Sometimes, so as I say, those lines do get blurred, and sometimes we don't know what the best course of action is. How do we decide the goal of the treatment? A lot of it will boil down to the biology, the staging of the cancer, but some of it also depends on the patient themselves. So somebody with a good performance status who was otherwise healthy just came into the hospital, has this tumor in just a terrible location, but we know should be able to tolerate this type of treatment. We definitely want to be more aggressive. So it also boils down to the patient. We definitely look at this in an individualized manner. So cancer care is always going to be personalized because no two individuals are the same. But these are the general things we look for. So the type of cancer, the stage of this cancer, the location of the tumors, the health of the patient. And then of course at the end of the day, we can talk about all of that, but if your goals are different from what our goals are, we need to ensure those align. wanted to talk very briefly about something a little bit more exciting, maybe from a radiation standpoint. We've been talking a lot about cancer, but over the last few years, we've delved really into treating more and more benign diseases. In fact, our last national conference was focused entirely on using radiation to treat benign diseases. I've highlighted a few, and I was going to talk briefly about arthritis and something called trigeminal neuralgias. We also treat things like keloids, heterotropic ossification, and Dupuytren's contractures that patients can develop on their hands. So osteoarthritis, it affects almost everybody I know. It's the #2 cause of disability in the US. Current treatments we know can be limited by side effects, so most treatments involve medications, anti-inflammatories. The issues with those drugs is they can cause cardiovascular side effects, GI issues. There's also reduced long-term efficacy over time. A lot of medications just stop working. And then, of course, surgical risks in older patients. Treating osteoarthritis with radiation is not something new. So it's actually been done in Germany for the last 3 to 4 decades. And in fact, in Europe, the most common reason for having radiation is not cancer, but a benign disease. So it just has taken a little bit of time for us to adopt it here in the US, but it's definitely here and it's coming. It's a very, very low dose of radiation, so less than 5% of our normal radiation dose we use to treat cancers with. And about 60 to 90% of patients get pain relief. It can be complete pain relief or partial pain relief. It has actually no real known side effects. So that's the amazing thing about this treatment. And it doesn't increase the risk of cancers.
You're talking about osteoarthritis. What about rheumatoid arthritis?
Unfortunately, different disease mechanism. Yeah. So with osteoarthritis, the reason you develop that is inflammation within the joint. And generally, high doses of radiation cause inflammation. But what we found is at very low doses of radiation, we're able to act as an anti-inflammatory. Whereas rheumatoid arthritis is really your body is causing this reaction. It's an autoimmune disorder. And unfortunately, radiation will not be as effective for that. So yeah, this is just for osteoarthritis. Yeah. We worry about secondary cancer risks in patients from radiation, but there's no added risk as long as we're treating those over the age of 40. So we don't treat patients that are younger with arthritis. And to be fair, the population we generally see is not those in their 20s or 30s. So who can be referred for radiation for osteoarthritis? Generally for older patients, as I mentioned, refractory pain, so pain that's not responding to medications, or there's a contraindication to taking the medication or surgery for that matter. Knees are very effective for treatment, as are hands, hips, shoulders, ankles. We've treated all types. It's just about 2 to 3 treatments per week over 2 to 3 weeks. They're short treatments. They're very, very straightforward plans, so it really just takes us a few days to plan it. Sometimes we do have to come back and retreat patients, so 6 to 8 weeks later we may need to do it again. But it doesn't interfere with any future surgery, so it can also be a bridging step between getting to surgery. This was a case I wanted to highlight. It was a lady I was seeing, 79 years old. She was diagnosed with stage 4 lung cancer in last summer. She was treated with chemotherapy initially, had a very good response, and we were going to do 3 weeks of radiation, so 15 treatments of radiation. However, when I met her, she mentioned she had quite severe right hip pain, and in looking at her chart, it was related to osteoarthritis, to the point where it was making it difficult for her to do that simulation scan for radiation. And so we decided, and I discussed this with her medical oncologist as well, is why don't we treat the osteoarthritis first? It seems a little counterintuitive to treat the benign disease first, but she was on high doses of morphine, also taking oxycodone, and still not finding any relief. So we treated it, 6 treatments over 2 weeks. Her 9 out of 10 right hip pain dropped to about a 3 out of 10. She was actually able to come off the morphine altogether during her radiation treatments. We were able to get her through the lung treatments. Her pain in the right hip did come back, however. It wasn't quite as high as the 9, but it was an 8 out of 10 a few months later, so she came back and asked, hey, can we do this again? I said, sure, why not? So, as of 1 month ago, it's about a 5 out of 10. So it hasn't gone away completely, but it's made it manageable, tolerable. I certainly have had patients, however, that have had immediate relief, long-lasting relief. There was a patient who couldn't open a water bottle because of the pain in her hand. And halfway through her treatment, she was actually able to open a water bottle in front of us.
So what is the radiation doing? You know, you talked about it sort of disrupting cells.
Mm-hmm.
In the case of osteoarthritis, what is it actually doing?
Right, in this case, it's almost acting as an anti-inflammatory. So most of the times when we deliver radiation, the body thinks of this as an adverse reaction, and it brings inflammatory cells in the vicinity of where we're treating. In osteoarthritis, however, it activates the anti-inflammatory cells. So it's a very, very low dose of radiation. So instead of targeting the inflammatory cascade, we target the anti-inflammatory cascade. And it's really only at this very low dose that that happens. If we go even a little bit higher, we cause the opposite effect. So the treatments work if they're given a couple of times, but after multiple treatments, we may actually be causing an inflammatory effect.
And why do you think that this has had such a uptake in Germany and not here?
They have capacity, I suppose, and believe it or not, but a lot of the advances in radiation oncology and cancer care will often take places at centers outside of the US. And coming from Canada, I can tell you the reason being is a lot of the healthcare systems are organized under one umbrella. So it's easy to do large population studies in places like Germany or Canada, just because we have the ability to put patients on trials in a very large population-based basis. So a lot of these advances do actually come from other centers, but once we see it, I think we can adopt it. And also, to be frank, reimbursement.
Does insurance cover it?
Now insurance covers it, but it didn't always. So we had to show and demonstrate that it is effective. There was, I don't know how much time we have. There was a study that they did in Germany initially, which they gave sham radiation to patients, which I don't think we could ever do here in the US. And so half the patients got sham radiation for arthritis, the others got real radiation. And they actually didn't find a difference in outcomes. And this was done about 2 decades ago. The type of radiation they were using was a little bit different. It was a higher dose of radiation. And over time, it was rebutted that and there's since been many trials that have shown the effectiveness, but that particular trial really pushed a lot of reimbursement issues for us. Yeah. Mm-hmm.
A few years ago, I heard a breast cancer oncologist refer to photon-type radiation as opposed to the new proton-type radiation, especially treating cancer,
Mm-hmm.
breast cancer,
Mhm.
that's close to your vital organs. What types are we talking about here?
Right. Photons are actually X-rays, so no different than X-rays. It's just how they're created. But yeah, a photon is an X-ray radiation, which is what we normally use. Most radiation facilities have photons. I didn't go into too much detail about how radiation is created, but essentially inside that machine, there's an electron gun that fires into a target, and it goes through a magnetic field and it just makes those electrons accelerate. So that's why we call it a linear accelerator. It's accelerating these electrons. They hit usually a tungsten target and they create X-rays. And those X-rays are also called photons. Protons, however, are essentially hydrogen molecules, and the way they're created is a little bit different. And we only have one proton facility here in Arizona, but everywhere else has photons. Sometimes we don't, we allow the electrons that are produced in that linear accelerator to just come out of the machine. And electrons on their own are sometimes used for radiation as well, actually for treating skin cancers, because they deposit their dose very superficially. Photons go a little bit deeper than that, and protons go very deep. So depending on the target, kind of depends on how we treat. But most breast cancer patients would get photon treatments. Yes?
I've been reading a lot about the new laser treatments and the new sound treatments. Is that falling in the realm of radiology?
It does not. It falls in the realm of radiology. Yeah. But it's not radiation treatment, so ultrasound, lithotripsy, things like that, ablative treatments. It depends on location in terms of who delivers those treatments. So again, I know a lot of my cases are based off of lung just because that's what I treat. But if there's a tumor in the lung that's sometimes already been radiated, can't have surgery, we'll often refer them for ablation. And if it's in the periphery, it's often the radiologist that will do the ablation through CT guidance. But if it's somewhere more central, it's our interventional pulmonologist that will do that ablation, and that's bronchoscopically, so going through the airway to do it. And there's another procedure called brachytherapy, which I haven't really talked about too much other than for prostate, but we have sometimes used that for treating lung cancers as well, whereby we can implant radioactive seeds very close to the airways. We do that, we've probably gotten away from it in the last few decades, but now with the advances with interventional pulmonology, we suspect some of those procedures may come into light as well. But I would say that's probably the only time we would do these type of ablative procedures is brachytherapy. Yeah. Yes?
What sort of side effects do people experience with radiation?
Absolutely, great question. I think I have a few slides at the end to address that, but it really will depend on location. With radiation, it's all about where we treat. There's probably two side effects that everybody experiences when they have radiation. One is fatigue, which is common for pretty much any cancer treatments, and the other is a skin reaction. Although now with our ability to target those tumors very in the vicinity of where we're treating, we see less and less skin reactions as well. But I'll go over it in a little bit in terms of location and what we see in terms of side effects. Do you have a specific site in mind?
No, but I wondered also, is it possible to have side effects like 3 months after radiation?
Yeah, so there's short-term and long-term side effects of radiation. So the short-term side effects, and the best example of it is actually skin reactions. The short-term side effects tend to start a few weeks into your treatments. And the reason being, if we're damaging a skin cell, 10 days into your treatment, that bottom layer of that skin cell normally gets to the top. You get a new layer develop every few weeks, every few months. Well, remember I mentioned that radiation prevents cells from dividing, so it's preventing that skin cell from dividing. So 10 days after you start your radiation is when you start to experience that acute reaction. It goes away after you finish radiation because, well, 10 days after you finish, your skin can now start to repair itself. But some of that damage the cells will remember, and think of it as a scar or fibrosis. We saw that case of that tumor in the lung where initially you really couldn't see much, but then 7 years later you can actually see a scar. The same thing can develop in other organs as well. So for example, if we treat close to the esophagus, you can develop a stricture in the esophagus, not right away, but years after. And so sometimes months after. The lungs can get damaged. We can develop inflammation in the lungs, not right away, but many, many months down the line. Head and neck cancer is one where we see a lot of long-term complications related to, again, these side effects related to scarring or fibrosis. So I was just talking to somebody about one of their family members that had radiation to the neck, and now their neck muscles are so stiff that they need physiotherapy for it. But it didn't happen right away, it happened months down the line.
And is fatigue one of them?
Fatigue, it's rare to have fatigue long-term from radiation, although we have seen some cases where people do develop just cancer-related fatigue. It's often in line with when we're treating with multiple modalities of treatment, so chemo and radiation. But in general, the radiation-related fatigue goes away with time. And we normally say within about a month of finishing. Sometimes it can last a few months. Yeah. What radiation does is it actually affects the cells in the salivary glands that produce the thinner, the mucus, as opposed to the thicker ones. So often during treatments, you'll be left with that thick saliva. We often recommend using, baking soda rinses just to help thin it out. But unfortunately, over time, you're dealing with that long-term side effect of radiation, the dry mouth. And there's not a whole lot we can do to make it better, but we have to manage the side effects.
Slightly better now.
Right. Is it all back to normal?
Overactive.
Wow, overactive. Okay, great to hear. Yeah. And to be fair, we don't always see this side, the many, many years down the line, because often once you're 5 years out, you get discharged from the cancer center, and we presume that you're still having those symptoms. So this is actually really nice to hear that came back. Yeah.
Dr. Clayton, I need to keep us on schedule.
Absolutely.
That's my job. Sorry about that. Are there other key points we missed here that you want to breeze through?
I think we can, we're past time. We're okay. Yeah, not to worry. I'm more than happy to take questions anytime. But yes, I'll try to keep us on track.
Thank you. Let's thank Dr. Clayton for everything. Yeah, I love this because I think what this helps us with is know what questions to ask, right? When you're seeing your physician. Now we're so much better informed about some of the modalities that are out there. So yes, if you can stay a few more minutes, if people have individual questions, is that how?
Absolutely.
What's your schedule?
I have 10 minutes.
10 minutes left. So again, so appreciate Dr. Clayton being here today, and look forward to some of the materials we'll be sending out to you about what advances are coming, what we're looking at doing in the MD Anderson support area on the Boswell campus. That will be forthcoming. I'm going to ask you to fill out this little sheet here, mostly because we want to know what else you want to hear. We have a lot of access to resources within the healthcare community. And so this one was fascinating, but there may be another particular area that you really care about. And so we'd love for you to fill that out and let us know what it is you want to hear about, or if there are other areas that you would like to hear from us, we would want to hear about that. So thank you very much for being here today. I saw the Loloma van driver, but he can wait a few more minutes to make sure that any of you who want to speak to Dr. Clayton have that opportunity. Take care. Have a great day.